medics. Today I'll be discussing on topic disseminated intravascular coagulation. I'll go in order wise. First I'll be discussing on definition, then etiology, then pathophysiology, then clinical features and your management part, which includes investigations and treatment. So first coming to the definition, how do you define disseminated intravascular coagulation? So when you define, write it as it's a widespread, okay, it's a widespread acute or chronic thrombohemorrhagic condition occurring as a complication to certain conditions. Okay, let me repeat. It's a widespread acute or chronic thrombohemorrhagic condition occurring secondary to the complications, okay, of certain conditions. So let me discuss those conditions, that is your etiology part. So you have got infections which cause DIC, which include malaria, meningococcemia and Rocky Mountain spotted fever. Then obstetric conditions which include your retained dead fetus and septic abortions, abruptio placentae, preeclampsia and amniotic fluid embolism. And other etiological factors are the conditions that cause tissue injury, massive tissue injury, which include your surgical operations, got massive trauma, and then burns which cause massive tissue injury. Other etiology are your pancreatitis, shock, snake bite, liver diseases. So this is the etiology of this DIC. Okay, DIC. So next, coming to the pathophysiology. What is the pathophysiology of DIC? Let me mention here only that what happens in DIC is initially there will be thrombotic stage. That means your clotting factors and coagulating factors and your platelets are getting consumed in the initial stage. Okay, then as time progresses, these clotting factors and coagulating factors, they reduce in the blood because they are not available. So what will happen, later there will be fibrin degradation and there will be bleeding stage. Okay, first there will be thrombotic stage and then gradually their bleeding occurs due to fibrin lysis. So coming to the pathophysiology, first initially what happens is there is tissue injury and endothelial injury due to the etiological factors that I have mentioned earlier. Okay, revise them. So tissue injury and endothelial injury is occurring. So tissue injury will increase the tissue factor. Okay, tissue injury will increase the tissue factor levels, and endothelial injury increases the platelet consumption. Okay, that is platelets are getting consumed in response to your endothelial injury. So there is platelet aggregation. So both these pathways, that is your increased tissue factor and platelet aggregation, there will be coagulation pathways occurring that will lead to thrombus formation. Okay, so I think you have understood. So when there is thrombus formation, this thrombus will occlude the blood vessels, smaller blood vessels, and the blood vessels that supply your organs in the body. So when they occlude, there is reduced blood supply or the blood supply is blocked. So what is happening is these organs are damaged, that is these organs don't work, that is your organ dysfunction. So many organs are involved, so we call it as multi-organ dysfunction syndrome. Okay, so next come to the clinical features. You have got thrombotic stage and hemorrhagic state. So what happens in thrombotic stage in the brain? When the blood supply to the brain is blocked, what will happen? The patient is confused there can be coma, there can be cognitive disturbances. But when there is hemorrhagic condition, there will be intracerebral hemorrhages. This is about the brain, friends. So in the skin, what happens? There will be gangrene when there is blood supply is blocked to the skin, and when there is bleeding, that can manifest as petechiae, ecchymosis. Okay. What happens in the kidney, friends? What happens in thrombotic stage? There will be oliguria, that is less urine is produced. Then azotemia, that is ammonia is getting increased in the blood, secondary to your reduced GFR in the kidney. And in the hemorrhagic type, you can see hematuria, okay, that is a blood appearing in the urine. And what happens in the mucosa? You can see bleeding gums, okay. In the nose, you can see epistaxis. In the GIT, in the hemorrhagic condition, you can see ulcers, GIT ulcers. And in the hemorrhagic condition, there will be massive hemorrhage within the abdomen. And other clinical features, important clinical features, are your adrenal gland hemorrhage occurring in the adrenal gland that can cause Waterhouse-Friderichsen syndrome. I think you're familiar with this term. What are all the other organisms that can cause Waterhouse-Friderichsen syndrome, friends? There can be which infection? Meningococci. Okay, this is the organism that causes Waterhouse-Friderichsen syndrome. Then other clinical features you can see is acute respiratory distress syndrome. The patient is having difficulty in breathing. Okay. Investigations that you can do in this DIC, that is disseminated intravascular coagulation, is platelet count, serum fibrinogen, prothrombin time, and activated prothrombin thromboplastin time. Okay, platelet counts. What happens to platelet counts, friends? It is reduced. Okay, then serum fibrinogens are reduced. Okay, so what happens when there is a serum fibrinogen are reduced is there is reduced ESR. Okay, include this point also. And prothrombin time is increased, activated prothrombin time is increased, and fibrin degradation products are increased. Which can be diagnosed by latex agglutination. One more test you have got is D-dimer test, which is again the D-dimer is increased. What is D-dimer, friends? D-dimer is produced when there is fibrinolysis by plasmin. So this substance is also increased in the blood. So we have to measure the D-dimer. Coming to the treatment, friends, in the thrombotic stage, you have to use heparin. Okay, use heparin. And in the hemorrhagic state, that is when there is a bleeding manifestations, you can use tranexamic acid. When you are using tranexamic acid, you can indirectly lead to thrombosis, because the fibrin, whatever fibrin is there, that is not getting degraded when you use tranexamic acid. So what will happen? There can be heparin. There will be thrombosis. So you can use heparin concomitantly when there is again thrombotic stage secondary to tranexamic acid. So other treatment modalities include your RBC concentrates and fresh frozen plasma and cryoprecipitates. So I think I have discussed most of the important points that you can include in your paper to get good marks, and this is also important clinically because there can be, when you are working in casualties or anywhere, so this thing should be popping in your mind, that when the patient is operated, when the patient is having burns, when there is snake bite, when there is a patient of pancreatitis, when there is a obstetric patient with some complications, DIC should pop up in your mind. Okay, keep this is an important topic, please remember. uh, okay, thank you friends for listening till here. uh, all the best. Thank you.